One, I call to order the roundtable discussion of the Rural and Underserved Communities Health Task Force. Thanks to all of you for joining us today for our first roundtable to discuss the role of telehealth during the COVID-19 pandemic and beyond. We're in the midst of a global pandemic that is bringing to light the disparities and faults in our healthcare system and underscoring why the work of our task force is so urgent. There are many issues demanding our attention these days, but there are few as important as expanding access to quality health care. I am so grateful to Chairman Neal for establishing this task force. I serve as one of the co-chairs of the Rural and Underserved Communities Health Task Force, along with Congressman Dr. Brad Winstrup of Ohio, Congressman Danny Davis of Illinois, and Congressman Jody Arrington of Texas. We are all very grateful for you all joining us today. As members of the task force, we have identified 4 policy areas to concentrate on moving forward: addressing social determinants of health, enacting payment system reforms, strengthening technology and infrastructure, and in reinforcing our nation's health workforce. The task force released a bipartisan summary of stakeholder feedback from its November 2019 request for information that touched on each of these 4 areas. The roundtable today marks the first step in the task force deep dive into policies at the intersection of all 4 areas of focus, but especially technology and infrastructure. We have an outstanding panel of experts today. They each bring a unique perspective on how we can make sure that telehealth works for all communities and that it meets its full potential for every American. To my fellow task force co-chairs, it's an honor to serve with you. I am energized by the passion and commitment that each of you bring to the table. Our districts are all unique and have different challenges, but we've been able to find more commonality than differences. Those commonalities are rooted in the reality that we all represent vulnerable communities who need a better health system designed to reach them wherever they are and to provide them with world-class health care that they all deserve. The unfortunate news is that we are behind. The COVID pandemic caught us flat-footed, and the promise of telehealth hasn't quite yet been realized for too many of the populations that we serve. But we're going to change that. I am delighted to see so many members of the full Ways and Means Committee with us today. Thanks to all of you for your interest and the work that you're doing on this issue, and as well as the task force and focusing on telehealth. I, of course, would be remiss if I didn't acknowledge that our fellow Ways and Means member, colleague, and dear friend, John Lewis, was one of the strongest champions for rural and underserved communities this country has ever known. He gave us a roadmap to not only legislate by, but to live by. We are all stronger and better policymakers because of what he taught us about standing up for the voiceless and the forgotten. I also want to thank our tremendous committee staff for your work in getting today's roundtable together and for the expertise that you all bring to our committee each and every day. I want to thank our staffs for putting this together. And with that, I'd like to recognize my fellow task force co-chairs for 5 minutes for their opening remarks. First up, Dr. Brad Winstrup. Congressman Winstrup, 5 minutes for your opening remarks.
Well, thank you very much, Terry. And first, I'd like to say that I want to associate myself with your words, and especially with the kind words from Mr. Lewis and the type of leadership that he always displayed. I really didn't get a chance to know him well until I got on this committee, and I'm grateful that God gave me the chance to know this fine human being. And just want to reiterate what you had to say. But I want to thank everyone here for joining us and my fellow co-chairs on the Rural and Underserved Communities Health Task Force. You know, last year, my colleagues, Representative Sewell, Arrington, Davis, and I formed this task force in order to address a variety of the problems that patients in rural areas are facing today. And I thank Chairman Neal for recognizing that this was of great interest for members on this committee on both sides of the aisle. And it was great that he brought us together to address this. And pleased to have people with us today. Thank you for joining us today, especially the experts that we're going to hear from. And, we set out to address really 4 areas for our task force, and that includes telehealth, reimbursement and payment models, workforce shortages, and what we've all come to call social determinants of health, which we all recognize are there and need to be addressed. But first, let me speak on regarding payment models and reimbursements. We all know too well that rural hospital closure crisis that continues to torment our rural communities, and our rural hospitals have unique needs. They have a skewed payer system. Their reimbursement is generally less. Their payer mix is generally skewed in a way that they don't receive as much revenue from the types of services they're providing as others. And they have lower volumes. And these are both obstacles to the traditional revenue that subsidizes critical care in most other communities. Second, we have a workforce shortage, both for doctors and for allied health clinicians. And we need to be smart about expanding GME, residency programs. And we also know that, and we've discussed this, that residents are more likely to end up practicing close to where they completed their programs. And so this means that we need more residency programs either directly in rural America or associated with rural America in order to get more doctors out to rural America. Third is telehealth, and it's important that we ensure that distance and transportation are not a barrier to care, which we know that's one of the biggest barriers that people face. And technology can be used to close this gap. Innovative remote monitoring, connecting patients with distance specialists, and even remote assistance and guidance for clinicians in the emergency room. These are all ways we can ensure access to care for rural Americans. And fourth, I know from speaking with my constituents and as a clinician for over a quarter century, there are a lot of factors outside the physician's purview that affect clinical outcomes. Housing, transportation, nutrition, access to food, all those things directly impact the symptoms we see when we see patients in the examination room. So these cannot all become the direct responsibility of the health profession, but we cannot treat them as separate silos from the federal policy level just because they fall under different committees or different departments. And I think that's one of the challenges that we face, is bringing all these entities together essentially under one roof so that we are addressing the patient holistically. So, today we've seen the stresses on our rural healthcare delivery system exacerbated by a COVID situation. One tool that our rural healthcare providers have used to stay afloat and our rural patients have used to continue to access care is telehealth. As we face this pandemic, my constituents in Ohio have had access to a key lifeline by being able to connect to their doctor from their home. And that's why some of my colleagues and I released a discussion draft as a start to the conversation on where telehealth legislation should go to make these new flexibilities permanent. So, however, as we go, we need to be smart about how we make these flexibilities permanent so we can protect American taxpayer dollars, but also provide better health care. And I hope that today's task force meeting will allow us to continue these conversations, make progress, and I thank our panel of witnesses for joining us today. Look forward to your testimony, and thank you for cooperating with us today, and I thank our fellow members for joining us. And with that, I yield back.
Thank the gentleman. And now we recognize that the task force co-chair, Congressman Danny Davis from Illinois, for 5 minutes for opening remarks. Danny, you may still be on mute.
That's it. Okay. Did we get it?
Yes, I can hear you now.
All right. Well, let me thank you for your leadership, and let me also thank all of the co-chairs. It's so good to work with you, Dr. Winstrup and Mr. Arrington. It's a pleasure. The spirit and the life and the work of John Lewis lives on and will live on forever. I've known of it for more than 50 years. He was a great hero of mine for all of those 50 plus years that I've known of what he did and had an opportunity to work with him. Trying to find approaches to deal with the health needs that exist in inner city, urban America, and rural America is a great task. And it's something that I think all of us are enjoying working on. Talking about telehealth, there are many barriers that still exist for the underserved in accessing telehealth. I'm going to focus much of my attention on community health centers, which serve more than 28 million low-income and disproportionately uninsured patients in rural and underserved urban areas of the United States. And they have not fared well during the pandemic, with significant drops in ambulatory visits, which have resulted in furloughs, layoffs, and more than 1,900 temporary site closures throughout the country. Many states have directed insurers to temporarily cover COVID-19 related services via telehealth, while mandating parity of reimbursement for telehealth visits with in-person visits for their Medicaid programs. But many community health centers are not prepared to replace in-person visits with telehealth encounters. In 2018, 56% of 1,330 community health centers did not have any telehealth use. 47% of those centers using telehealth were doing so only with specialists, such as those at referral centers rather than with patients. Of those using telehealth, 68% used it to provide mental health services. 30% used it for primary care or management of chronic conditions, 21%.
What is the Wi-Fi here?
Of those not using telehealth, only about 1 in 5 were in the process of actively
What network is
implementing
it?
or exploring telehealth. Community health
Yeah.
centers not using telehealth report the following barriers. 36% cited lack of reimbursement, 23% lacked funding for equipment,
We've lost Congressman Davis. Congressman Davis, can you you're going to have to unmute yourself again. Apologies.
I think we may be back.
Yes, you're back.
Okay.
And we'll give you more time, sir. So just pick up where you left off.
All right. In 2018, 56% of 1,330 community health centers did not have any telehealth use. 47% of those centers using telehealth were doing so only with specialists, such as those at referral centers rather than with patients. Of those using telehealth, 68% used it to provide mental health services. 30% used it for primary care or management of chronic conditions, 21%. Of those not using telehealth, only about 1 in 5 were in the process of actively implementing or exploring telehealth. Community health centers not using telehealth report the following barriers. 36% lacked reimbursement. 23% lacked funding for equipment, and 21% lacked training for providing telehealth. More rural than urban clinics reported inadequate broadband services. Currently, there are 14 million people living in urban communities in the United States who cannot access telehealth. In the 111 largest cities in the United States, people of color comprise 75% of unconnected households. This year, the Federal Communications Commission and the USDA will spend $5 billion to provide telehealth and broadband to 4 million rural households. At the same time, the FCC's spending for its urban subsidy program, Lifeline, has dropped from $2.2 billion to less than $1 billion. And current FCCC grants do not provide broadband access to private homes. Finally, studies published this week in the Journal of the American Medical Association found that more than 41% of Medicare beneficiaries lacked access to a computer with high-speed internet access at home. A similar number did not have a smartphone with a wireless data plan. 25% did not have either option. The proportion of Medicare beneficiaries with digital access is lower among people who were 85 or older. With it, had a high school education or less, were Black or Hispanic, received Medicaid, or were disabled. 38% of those older than 65 have trouble with video telehealth because they are inexperienced with technology and or have difficulties and disabilities that interfere with the successive use of public health. And so barriers are there, but optimism exists, and we think we're still on the way. And I yield back.
Thank you so much. The gentleman's time has expired. Next up is Task Force Co-Chair, Congressman Arrington from Texas. The gentleman has 5 minutes. You may have to unmute yourself, Jody. Jody Arrington? I think we're going to just proceed with our until Jody, you may have to unmute yourself.
Congresswoman, I don't believe he's on.
Okay. We will then proceed with introduction of the panelists. Now I'd like to welcome our distinguished panelists for today to discuss the role of telehealth during the COVID-19 pandemic and beyond. I want to thank each of them for taking the time to share with us your insight on how we can make sure that telehealth reaches its potential in every community. First, I'd like to welcome Tarantini Carlyle Davis. Dr. Davis is the Director of Clinical and Advanced Practice Operation at the University of Mississippi Medical Center's Center for Telehealth and Assistant Professor for the School of Nursing. The Center for Telehealth at the University of Mississippi is a beacon of excellence when it comes to telehealth delivery in underserved communities. I'm especially anxious to hear from you since I've heard so many great things about the Mississippi telehealth model. So I'm pleased that Dr. Davis is with us today. Next, we will have Dr. Atav I've just brutaled your name, Maratra. Dr. Maratra is an associate professor of healthcare policy at Harvard Medical School's Department of Public Health and Health Policy. We are also joined today by Ms. Karis Myrick, who is the Chief of Peer and Allied Health Professionals for Los Angeles County Department of Mental Health. Previously, she served as Director of the Office of Consumer Affairs for the Center of Mental Health Services at the Substance Abuse and Mental Health Services Administration. Finally, we are joined by Dr. Jason Tibbles, who serves as the Chief Quality Officer at Teledoc, where he is responsible for leading their clinical strategy. Dr. Tibbles is a family physician in Decatur, Texas. I would like to again thank all of our panelists and advise you that you're asked to summarize your statements in 5 minutes or less. To help you do so, there is a virtual clock that should be pinned to your screen. Dr. Davis, you're the first to begin. Dr. Davis.
Thank you so much. Special thanks to Chairman Neal and the co-chairs of the House and Ways Committee Rural and Underserved Communities Health Task Force. First, I would like to express my gratitude to each of you for giving me the opportunity to share about something that I believe is a major force in healthcare today. The University of Mississippi Medical Center is the only academic medical center and level 1 trauma center in the state of Mississippi. It is the expectation that the medical center be a leader in cutting-edge advancements that promote and preserve the health of the residents of our great state. As one of the 2 national centers of excellence in telehealth, as designated by HRSA, the University of Mississippi Medical Center Center for Telehealth has worked tirelessly over the past 17 years to position ourselves as leaders in telehealth. Our work to provide access to specialty care to those areas has served as a model for others. Not only does our work focus on the delivery of direct patient care, but we support rural providers using the ECHO model to connect them to specialists not accessible by other means. UMMC's vast experience in telehealth proved beneficial not only to the medical center, but to our state's public health system as well. Specifically, we were able to support our Department of Health by repurposing our direct-to-consumer platform to create a statewide COVID-19 screening and testing program within a matter of days. Pre-COVID-19, concerns about cost, workflows, and the patient experience fueled hesitation and adoption for many providers. There were also other barriers such as geographic restrictions, interstate licensure, malpractice issues, and reimbursement variances. This hesitancy quickly transformed into urgency as COVID-19 concerns drove many healthcare providers to look at ways to serve their patients in a safe but efficient manner. Within a matter of weeks, we were able to leverage our existing platform to train 12 clinical departments by conducting nearly 100 training sessions on operationalizing telehealth in their respective areas. Within 30 days, telehealth visits increased by 286%, and 361 new users were trained. The loosened restrictions for sites of service and enhanced reimbursement structure provided the opportunity for providers to continue to care for their patients during this public health emergency. Many patients were eager to try this new technology as they attempted to adhere to the shelter-in-place orders. An example of this is the child with a mental health diagnosis who was not able to come to clinic during this order. The guardian also suffered with mental illness and was so anxious about the thought of coming out that they could not bring the child in. Because of the relaxed restrictions, our practitioners were able to connect with the patient in their home and send the prescriptions to their pharmacy, preventing a delay in care. While this was not necessarily the way we wanted to expand telehealth, it has been more than effective. It is our hope that the flexibilities in telehealth made available to us during this public health emergency remain in place, specifically those around sites of service and reimbursement. Thank you for your time and attention today.
Did you say, should I go ahead?
Yes.
Great. Well, thank you to the task force co-chairs and other distinguished members of the committee. I'm honored to speak before you today on a topic of such importance to Americans and their health. My name is Dr. Ativ Mehrotra. I'm a physician at the Beth Israel Deaconess Medical Center and an associate professor at Harvard Medical School. And my research focuses on the impact of telemedicine. Has it improved people's access to care, particularly in rural communities? Is it improving quality? And what impact is telemedicine having on healthcare spending? I've studied a wide range of telemedicine applications from the treatment of mental illness to strokes. And I do this research because I hope telemedicine can help a common complaint I hear from my patients and what I'm sure you hear from your constituents, that namely people often have difficulty accessing care in a timely manner. My statement is organized around three key points for you to consider as you decide on the future of telemedicine policy. The first is there is great urgency in determining the post-pandemic telemedicine policies. As you are well aware, Medicare and many private health plans have temporarily waived regulations and broadly expanded reimbursement. And in our research and the research of others, we've documented a sudden and dramatic rise in the telemedicine use across the United States in March. But since then, the use of telemedicine has steadily declined, and the use is now at roughly half of its peak. Why? Implementing a video visit is not easy. To do it well, a clinic has to buy the appropriate technology, spend a lot of resources training staff and patients on how to use it. In the midst of stay-at-home orders, providers developed workarounds, and frequently, because of technology problems, the video visits reverted to phone calls. Now that in-person visits are an option, many providers are deciding that investing in telemedicine is not worth it because they're uncertain on whether it will be reimbursed post-pandemic. So providers need to know now what telemedicine policy is going to look like post-pandemic. The second point is that telemedicine's strength is also its Achilles heel, and it is important to have checks on overuse. I'm often asked, why do we even need telemedicine-specific policies? And I believe it's because telemedicine's ability to make care convenient and more accessible, the key to its enormous potential to improve the health of many patients, is also its Achilles heel. I'm very skeptical of claims that telemedicine is broadly going to reduce spending, because to reduce healthcare spending, telemedicine visits need to replace in-person visits. However, our research suggests that telemedicine results in greater use of care. That is because people who otherwise would not receive care now get it. And if this greater use of care leads to substantial improvements in health, then this is good for our society. However, the concern is that much of this new use could be overutilization, or as we term it, low-value care that's really not improving health. Therefore, I think it is necessary to have policies that limit the overuse of telemedicine. So how does one balance the goals of encouraging high-value telemedicine and innovation while discouraging fraud and uses of telemedicine that do not improve health? Let's be frank, it's a very difficult balancing act, but let me offer several recommendations. The first is, whenever possible, encourage greater use of alternative payment models to providers that give those providers the flexibility to use telemedicine in a manner best suited for their patients. I believe flexibility in payment encourages innovation. I believe we should make permanent many regulatory waivers that were introduced during the pandemic, such as requirements that a patient be hosted for a telemedicine visit in the Medicare program. Despite the laudable reasons underlying these regulations, I believe they have hampered uptake of telemedicine, do not effectively encourage high-value uses, and impede innovation. I think the focus of the policy debate should be on covering telemedicine for patient populations where access is difficult, such as nursing home residents, those who live in rural communities, and for people who have substantial disability. And for the rest of the population, I recommend only selected coverage of telemedicine. And lastly, I argue that we should pay for telemedicine visits at lower rates than for in-person visits. While I fully recognize that implementing telemedicine requires substantial short-term investment, in the longer term, a provider's cost of telemedicine visits should be lower than in-person visits, and then payment should reflect those lower costs. Thank you again for this opportunity, and I look forward to your questions.
Thank you, Doctor. Next up, we have Ms. Myrick. Ms. Myrick, you may begin.
Yes, thank you. Thank you, Chairman Neal and co-chairs, for the opportunity to address the issues related to telehealth for those in most need in this country. The information that I'm going to be providing is based not only on qualitative information from stakeholders here in Los Angeles County, as well as from those around the country, but also from my personal lived experience of being diagnosed with a serious mental health condition and previously being on disability. During this time of social distancing, our communities are relying on internet and phone to connect to each other, loved ones, healthcare, and education. There is no more important time than now to ensure that people can have access to equipment and plans that support connection in a world that is forced to be physically disconnected. For those with mental and substance use disorders, isolation is basically a killer. We know the importance of social connection. In fact, some argue that social inclusion and connection is a medical necessity. When I was on disability many years ago, Lifeline, the Fcc program, was indeed a lifeline to ensure that I could stay connected with my family and with my providers. Limitations, however, at that time and even currently resulted in strategic use of my phone and internet access. I always had to check my minutes to make sure that I had enough or that I didn't go over and have my phone terminated so that I could call my doctor in an emergency and or my family if needed. Imagine doing that when you're ill and trying to do your best to get better. New legislation and reduction of barriers has indeed been a catalyst to jettison behavioral health into the telehealth digital age. However, the immediate response to remove the provider side barriers and limitations has not taken into full consideration the consumer side of the equation. So those on the receiving end of the telehealth equation were basically left out. What I've learned from our consumers in LA and nationally is not only that they don't have access, but how are they using their phones? What are they doing with the information, with their equipment? A lot of that is not captured in data points, and you can't find it in literature. In California, we're involved in a technology project to integrate the use of digital therapeutics within public mental health. What we're finding is people who have phones not just share them with their family, but when they don't have money, they rent them out to other people. Sometimes they have to sell them and they turn around and they buy things like pay-as-you-go phones, which again creates limitations when they need to stay within a budget. We found that the plan limits and slow internet speeds impacts ability to download apps such as the telehealth app. We also found that people who were unhoused may have phones, but because everything was shut down, they couldn't even charge the phones and then participate in care because they couldn't go to coffee shops and libraries and the like. For our communities that are English as a second language, monolingual, or low literacy, use of digital technologies can be a barrier if the technology is not easy to understand or follow directions. In Los Angeles, peers have created digital health literacy curriculum. They are working with the people we serve to help them use the telehealth platforms. One of the things we found out is that people don't even know how to show up sometimes to a telehealth appointment, that they would be driving through the drive-through of the McDonald's or going to the grocery store while they were having a telehealth appointment. Smartly, they would try to use the bathroom as the only place in shared living where they could have some privacy to get on the telehealth appointment with their providers. Unfortunately, sometimes they were literally using the bathroom. So we had to teach people, no, you cannot do that. You can go in, and how do you do that? By putting the seat down, sitting, the shower curtain behind you, etc. So we had to teach people about telehealth etiquette. The Fcc Lifeline program removed several barriers during this time, but we need more to be done to ensure those that are most vulnerable can access telehealth and other virtual health-related activities when and where they can best participate. We need to make sure that people can rapidly get through the enrollment and verification process for the Federal Emergency Lifeline Program. If I had any wish for unserved and rural community members, it's that they, like any other Americans, can have easy and timely access to telehealth and other virtual health platforms to support their well-being, especially during this time and beyond. Social connection is like air. We need it to live and flourish. Addressing the social determinants of health now includes digital technology and tools to flourish now and in the future. So I want to make sure that people have access in this nation and that everybody is fully arriving into the digital age and no one is left behind. Thank you.
Thank you, Ms. Myrick. Next up is Dr. Tibbles. Dr. Tibbles, you may begin.
Thank you, Congressman Sewell and co-chairs of the task force. I want to thank you for inviting me here today on behalf of Teladoc Health and for the opportunity to share with each of you virtually how telehealth is transforming the U.S. healthcare system. Before I begin, I just want to pile on and express my condolences to everyone that's grieving the loss of Representative Lewis. He was a great leader, a wonderful man, and his best. I'm Jason Tibbles, and I serve as the Chief Quality Officer at Teladoc Health. I'm also a practicing family physician and have witnessed firsthand the power of telehealth and how virtual care is enabling providers across the country to deliver safe, effective, and high-quality care. During the pandemic, telehealth has proven to be a lifeline and is providing Americans with access to critical healthcare services while keeping vulnerable patients out of clinics and hospitals. Teladoc Health partners with employers, hospitals, health systems, and more than 50 health plans in the US to deliver virtual care. We serve more than 40% of the Fortune 500 employers, as well as thousands of small businesses, labor unions, public sector employers, which all offer our virtual services to their employees. And we also serve almost 11 million federal health program beneficiaries. Today, I hope to share our insights on the critical role technology has played during the pandemic and why Congress should continue to provide Americans with access to safe, effective, quality care. What we know from data thus far is that Americans are eager to embrace virtual care. And while COVID-19 is driving patient volume now, we are seeing sustained demand in areas that are no longer considered hotspots in some states where the curve is flattened. We are seeing twice as many patients this year as we did same time last year. All in all, we've seen utilization of services stabilize at a level 40% higher than prior to COVID, not accounting for seasonality, and expect total visits this year to be near 10 million. In my experience, when many people think of telehealth, they envision a video consult like this with a physician treating minor conditions. However, as has been mentioned, telehealth has been successful in countless use cases. For example, used to expand access in underserved communities to specialists in low supply, cardiologists, neonatologists, others, reducing delays in treatment and improving outcomes while keeping patients in their communities. These types of care models are already in use in rural and underserved areas across the country and would expand with continued support from Congress. Many here today, including myself, have expressed righteous concern about the potential for telehealth to drive disparities in health inequities. Telehealth is not the silver bullet that will solve the very deep, long-standing social and structural challenges facing healthcare. But when implemented thoughtfully, there is incredible potential for virtual care to improve outcomes that matter for everyone. My colleagues and I believe deeply in the promise of technology to eliminate the barriers of time, distance, and geography, and are committed to helping solve one of the most unfortunate truths about US healthcare, that your zip code dictates your health outcomes and life expectancy. There's already bipartisan consensus on several legislative proposals to modernize telehealth under Medicare. At a minimum, Congress must act to permanently remove the geographic restrictions on where a patient must be located to utilize telehealth. 2, remove outdated originating site restrictions that limit access from the home, while being very careful not to add additional barriers such as requirements for prior in-person relationships. However, reform efforts must be coupled with significant and targeted federal investment to help bridge the digital divide and ensure that technology does not become a barrier to the very patients that we are working hard to expand access to. This pandemic has revealed anything, it's that moving forward, connectivity will be critical, not only for healthcare, but for education and ensuring all Americans, both urban and rural underserved communities, are not left behind. We may be closer to closing this digital divide than some think. Most of what we know about how patients access virtual care is drawn from a pre-COVID environment. Things have changed, behavior has changed. And I suspect that as researchers look more closely at data in the coming year, we'll see broader penetration of smartphone use and data plans among underserved populations. As Congress decides how to best move forward, many factors should be considered, but the greatest threat to healthcare equity may be not taking action to expand telehealth for the most vulnerable. Thank you again to the task force co-chairs and the Ways and Means Committee on opening discussions on these very important issues. I look forward to the discussion and will welcome your questions.
Thank you, Dr. Tibbles, and to all of our expert panelists today for your testimony. Before I move to member questioning, I wanted to give task co-chair Representative Jody Arrington an opportunity to give his opening remarks. Jody?
Well, thank you, Terry. It's an honor and joy to serve with you and Danny and Brad. And I'm talking, I know I'm being a little informal by calling you by your first names, but we're talking about rural America, and that's how they operate. They're just hardworking people, and they want a chance to be successful, which means just put food on the table and provide for their families. Access to healthcare, I think, is the heart of sustaining rural communities. What's at stake if we don't? We won't have food security, which is national security. We won't have energy independence, which is national security. So rural America represents the energy basin for the United States, the breadbasket for the United States, and I'd submit to you, more importantly, the backbone of this country. And this is key. We can get the Farm Bill right, we can get trade deals right, and it was awesome to work with colleagues on both sides of the aisle to get USMCA and other trade deals, and that's what it's good for America when we're all working together towards goals that will help strengthen our economy and the rural economies. But I think you can get all that right and not provide access to healthcare for these next generation or new generation of ag and energy producers, and they'll leave because at some point they've got to be able to provide basic care for their families. Anyway, I'm glad to be a part of this as a former CEO, president of a telehealth launch a year prior to me coming to Congress. I saw the benefits firsthand in connecting rural communities and keeping people out of the emergency room. There's just a host of things that we can do. And I don't know, Terry, that there's anything that in healthcare that will meet all three of the key objectives of quality, access, and cost like technology. So COVID's had a lot of bad things. We're going to overcome them as a nation. We're going to do it together. But one of the silver linings is that we're pushing technology and the utility of technology to a place where we can maximize its impact. I think that's a great thing. So I look forward to doing, the administration announced some things that I was encouraged by, recently. But the question is, what can we do that where their authority stops and ours begins? And I'm excited because rural people, at the end of the day, leadership is delivering results. And I know between you, Danny, and Brad, and our broader colleagues on Ways and Means, we're going to deliver on this. It's just too much is at stake. God bless, and thanks for letting me have a word or two.
Thank you so much, Congressman Arrington. Members will now each have the opportunity to question our panelists for 3 minutes. I will first recognize the co-chairs of the Rural and Underserved Health Task Force, followed by the other members of the committee in the order of seniority. If you have stepped away when your turn for questioning comes up, we will come back to you when you return. I will begin by recognizing myself for 3 minutes. When I think about how we can measure telehealth success, I think about the most remote areas of my Alabama congressional district, where there is only one doctor in the county and residents have to travel an hour or more to the nearest hospital or further for specialty care. When the resident of that county can access the best practitioners via a telehealth appointment when it is clinically appropriate, that's when we know that we've met our goal when it comes to telehealth. That's my goalpost. Dr. Davis said something in one of her articles in 2015 that I found poignant and relatable to my Alabama district. She said, "For you and I, an hour may not be a big trip, but for some of these patients, never leaving their communities. So if they need to see an endocrinologist or an ophthalmologist because they're losing their eyesight, chances are they are just going to have to lose their eyesight." The chronic illnesses that make my constituents more vulnerable to COVID-19, morbidity and mortality, is exacerbated by the lack of access to primary care that plagues these communities. While not a panacea, telehealth is one of the best tools we have at our disposal for providing more timely access for certain health conditions. One of these chronic illnesses that disproportionately impact my constituents is diabetes. One of the strongest risk factors for COVID mortality and morbidity is diabetes. So Dr. Davis, my question is to you. Can you tell the committee more about the Mississippi Diabetes Telehealth Network and the success of that program and what we can learn from your success? Dr. Davis.
Yes, thank you. My pleasure. So the Mississippi Diabetes Telehealth Network was a collaborative network. We knew that the University of Mississippi Medical Center could not do it alone. So we worked with a rural health clinic that was located in North Sunflower County, Mississippi. Thankfully, this rural health clinic was also attached to a hospital, small rural hospital. The patients or the people living in that area would have had to travel either to Memphis or to Jackson, for any specialty care that they would need outside of that hospital system. So we created a network for our remote patient monitoring program. It was focused on diabetes at that time. It has since expanded to other chronic illnesses. The primary care providers in that area continue to care for that patient as they normally would. That's very important because we believe that we should be supporting our rural providers in any way that we can. What we added to their healthcare was we added the specialists in this program. We had an ophthalmologist that was a part of this program that did the ophthalmology screenings through telehealth. We taught the staff at the clinic how to do the retinal exams, take the images, store them securely, and send them to our ophthalmologist here at the medical center, who then reviewed those and would send recommendations back to the clinic. This is very important because while we did have some patients that still had to travel to the medical center, those patients knew that there was something that needed to be treated. Chances are, if their primary care provider would have said, we need you to go to Jackson, so they can check your eyes out, they probably would never have shown up. But because we were able to tell them there is a cause for concern and you need to come so we can do whatever the procedure was, they were more likely to show up for those appointments. The patients also liked kind of having a one-stop shop for that program. So I think the biggest thing that we could learn from that is that there still has to be a form of collaboration for telehealth to be effective.
Thank you very much. I now recognize Task Force Co-Chair Dr. Brad Winstrup for 3 minutes.
Well, thank you, Terry, and thanks everybody again for being here. A couple months ago, several of us got together and having a discussion on some of the things that we may want to consider. And some of the things we came up with were, this is with telehealth, eliminating where patients are restricted to receive telehealth so they could do it from the convenience of their home, permanently reimbursing FQHCs and RSCs for telehealth services, maybe having telehealth services available at an FQHC for a specialist that may not be at the FQHC, and allow telehealth services to be provided by audio only by telephone. And I can tell you, for practicing for almost 3 decades, we always did telehealth. It was a telephone. And we talked to our patients on a regular basis when they called with a question. And as phones advanced, they started sending pictures of a wound or whatever the case may be they wanted us to see. And over the last few months, we've obviously seen incredible expansion as far as access through telehealth. And we know it's not the silver bullet. I'm a firm believer as a provider of, the hand on the shoulder and the holding of the hand and reducing anxiety of patients through that personal touch. But at the same time, if it's not always readily available, we want to be able to provide care. In many of the rural areas, broadband coverage is an issue. The Trump administration on Monday issued the Rural Health Executive Order. I look forward to see what comes out of HHS and USDA and the FCC. But broadband isn't the only policy challenge with telehealth. Some researchers worry about overutilization. I understand that. And I think one of the ways to curb this is through value-based care. Dr. Maratra, I hope I said that right, you brought up a lot of very good points that can be discussed. One of them was alternative payment models. I know that one of our children's hospitals in Ohio took a Medicaid program where they get a per capita rate, and with Medicaid. And one of the ways they make it work is keep those children healthy. So it's up to them to be proactive in keeping the children healthy, because if they do that, then they can make it work as far as economically make it work. And I've been saying for some time that, we always talk about lifespan, and, we want people in America to have a longer lifespan, which we do. But I think it's also important that we focus on health span. How do we keep people healthier longer? And so the alternative payment models can kind of drive that type of thing. And I do think it's important that you know your primary care doctor. And you mentioned selective use, and I'd like you to talk more about what I just mentioned, get your further thoughts on that, and expand on some of the things you talked about in your opening statement, if you would, Doctor.
Yeah, so thank you very much. I think the first point I'll emphasize that I really touched upon that you alluded to was the alternative payment models. I want to emphasize that when we think about the use of telehealth, it goes beyond just video visits or phone calls. There's a lot of ways that we can provide care, from text messages, and I think many of you have also used patient portals where you can communicate with your providers. But trying to think of a payment model where you pay for each text message is kind of really hard to figure out how the heck Medicare is going to, 10 cents, we don't know. So it does emphasize, but there are this plethora of different options. So to the degree that we can pay your primary care physician with the terminology cap, partial cap, all these different terms, but really give the physician, here's a dollar sum, take care of your patients as you see best fit. If it's a text message, a phone call, or whatever it might be, that's going to really be able to strengthen their ability and give them that flexibility to do what serves that particular patient well. So I'm very enthusiastic about those models, and to the degree that the growth of telemedicine encourages us to use those models more, I'm very enthusiastic about that. Representative.
No, I was saying I don't want to deliver a claim for every. I don't want to submit a claim for every.
The gentleman's time has expired. Apologies. The gentleman's time has expired. But I now recognize the task force co-chair, Congressman Danny Davis of Illinois, for 3 minutes.
Thank you, Terry. And I want to thank all of the witnesses. I was particularly struck, Dr. Davis, with your testimony, especially given the fact that Chairman Bennett Thompson and I both have worked with health providers in Mississippi, probably before you were born. But Benny and I both worked in health centers. He in Mississippi, I in Mississippi, and other places as well. You mentioned in your presentation that the University of Mississippi Medical Center has been training other colleges and universities, are conducting programs at the other colleges and universities. Could you explain what that program is like?
One of the things that we do is we are now in the process of incorporating telehealth education into all of our medical programs. So we're teaching in our School of Nursing, we're introducing them to telehealth because we believe that when they go out into the workforce, more than likely, they will be in a place where telehealth is being used. The same for our physicians. But aside from in our colleges and universities, one of the things that we pride ourselves in is teaching our rural providers how to use telehealth. What we do is we make sure that we present at their association meetings. We provide on-site trainings for them, and now in the midst of COVID, we're doing virtual trainings for them. When we go out to these places, we're not only suggesting that they use our UMMC specialists, but we're showing them how they can use the specialists that they already have, on site. One way in particular is in the community health centers, because we know that our larger community health centers have more than one location. So it's that pediatrician may not be able to travel, to each location when a child presents in the place. So, we're showing them how they can use their own to their other sites, where their patients are. One of the things that we're really proud of is our mental health program, where we have the mental health providers but we're connecting with the rural health clinics and the FQHCs to be their mental health provider virtually. That helps them be able to serve their patients in a more holistic manner, and it actually supports the integrated care model, which we know primary care and mental health should be working in close collaboration.
Thank you very much, and I yield back.
Thank you.
The gentleman's time has expired. I now recognize the task force co-chair, Congressman Arrington, for 3 minutes.
Can y'all?
We can hear you.
Can you hear me now?
Yes.
I thank the chair lady for her patience with me. You can take me out of the country. I sure hope these telemetry consults go better than my being able to access this teleconference. Look, I think Winstrup made a good point, and I want to ask the broader question: how do we prevent the waste, fraud, and abuse? Look, I'm all in on telemedicine, telehealth. I'm a believer in it. I've been a practitioner of it, and I've seen the results. And we've got to use it, but we've got to have guardrails in place so that people aren't just abusing it for sort of a fee-for-service churn. That is not the point of this. The taxpayers have to be protected in this. I get the value-based system approach. If you have a per capita cap, if you do the sort of risk model like that, then it's up to those providers and those groups to find the best ways, most efficient ways to deliver on the right outcomes. But outside of the value-based model, I don't know how you do it. So my question, Mr. Tibbles, Dr. Tibbles, again, what guardrails would we put in place to prevent those abuses from happening?
Congressman, thank you for the question. And just by chance, I was in your district last weekend, dropping one son off at Texas Tech while my oldest son is graduating with his BSN and is starting as a critical care nurse there at the University Medical Center soon.
That's great. Guns up.
First, I want to pile on to what's been said by the rest of my colleagues, that I do think that the huge value in telemedicine really shines in a value-based payment model.
Yes.
But as you mentioned, we're still very much in a fee-for-service world. I think it's important as a first principle to agree that arbitrarily restricting telehealth coverage for seniors, including things like mandating prior in-person visits, geographic site restrictions, and these things are not a viable program integrity strategy for federal health systems, which I think you would agree with.
Yes.
We've seen in many other industries, banking, financial, others that have been completely digitized. We found ways to use technology to address fraud in those sectors, and we don't require people to go to the bank to get their money. I would note that HHS, OIG, CMS have extensive program integrity policies and procedures in place to fight fraud, waste, and abuse and improper payments. We need guardrails, but these agencies need support from Congress to invest in innovative strategies, public-private partnerships, AI, predictive analytics, and capabilities to support enhanced audit and investigative efforts. And so I think we have to appropriately fund program integrity and enforcement initiatives, put the appropriate guardrails in place. And as you said, this is not easy.
Thank you, Dr. Tibbles. Madam Chair, how much time is remaining?
You have no more time, sir.
Okay, well then I yield back.
The gentleman yields back his time. I will now proceed in the order of seniority with the rest of the members. First up is Chairman Mike Thompson. I specifically want to thank Chairman Thompson for his leadership on telehealth. He is co-chair of the Telehealth Caucus and introduced comprehensive legislation just last month to expand telehealth. Chairman Mike Thompson of California, you are recognized for 3 minutes, sir.
Chairwoman Sewell, thank you very, very much. And thank you to your co-chairs of this task force for having this roundtable today. As many of you know, our colleague, Congressman Schweikert, and I are the co-chairs of the Bipartisan Congressional Telehealth Caucus. And telehealth is something I've been working on for 30 years, back to my days in the state Senate. And I think that we can all probably agree that telehealth has been one of the very few silver linings over the course of this pandemic that we're struggling with. And we've seen more telehealth in the last 6 months than we've ever seen before. One provider in my district went from providing about 300 telehealth visits a month to 3,000 a month for mental health patients. And I have a hospital that went from less than 1% telehealth visits to over 60% of their visits being telehealth. So it's an exciting time for telehealth. And it's also, I think, important to note that we've introduced new legislation, and the bill that we've just recently introduced will make a lot of the telehealth expansion that we've seen in COVID permanent. It would eliminate requirements that folks be in rural areas to get care, allow seniors to get care at home, make permanent the care at FQHCs, and ensure that we can expand healthcare in future disasters. And it would be the most sweeping expansion of telehealth ever. So I would encourage you all to look at that. I have a couple of questions, and I'd like to start with Mr. Tibbles. Sir, Teledoc, thank you to all the witnesses for joining us. Teledoc was one of over 200 organizations to endorse the bill that I introduced last month with Mr. Schweikert, and I thank you for your support. Can you talk a little bit more about how originating site restrictions, which our bill would largely eliminate, make it harder for patients to get the care that they need?
Sure, Congressman Thompson, thank you for the question, and thank you for your longtime support of telehealth. You know, for years, Medicare has, I would say, severely limited telehealth services, while other payers increasingly covered telehealth to provide care to patients. And this disparity became very clear during the pandemic. And you know, as in-person care was not really an option. You mentioned dramatic Medicare beneficiaries were in a given week went from 14,000 pre-COVID to the period from March to July, over 10 million beneficiaries. And you asked specifically about originating site restrictions, and I'll call back to some of the other comments earlier from your colleagues around the significant importance of eliminating problems with transportation, distance, and in fact, just eliminating the idea that geography is a barrier to care, I think is incredibly important. I love your bill. I think it's important Congress sends a very clear signal to patients who are very concerned about the future of their telehealth benefit, as well as has also been mentioned a few times, providers who are asking questions about what investments to make here. They're maybe a bit hesitant. So Congress has a great opportunity to finally bring the U.S. healthcare system to the 21st century. And also, by the way, ensure that the billions of dollars that you guys have put into this effort during the pandemic are not wasted. So again, thank you for your support of telemedicine reform.
Thank you. Madam Chair, I've got some other questions, and hopefully we'll get another round. But before I yield back, I just want to let the witnesses know that one concern I have is that telehealth has got to be accessible to everyone. And right now it isn't. You need broadband, you need to be able to afford and use the technology, and there are a lot of barriers there. So maybe on the second round I can get to that, but I'll just give the panelists an idea of what I'll be asking and give you some time to think about that. Thank you, Madam Chair, and I yield back.
Thank you. The gentleman's time has expired. I want to remind everyone that if you're not speaking, to please mute yourself so that we can hear the answers to these questions unfeathered. The chair now recognizes Congressman Adrian Smith from Nebraska. Congressman Smith.
Thank you, Madam Chair, and certainly thank you to our panelists and everyone participating here today. This is obviously a great opportunity and very timely as we put our heads together and get expert testimony, ideas, insight. So thank you. I've been working on some telehealth issues for a while now, even predating COVID, obviously, and the RUSH Act that I introduced with the support of many colleagues to replace unnecessary emergency room visits with telemedicine so that we could connect ER docs with the long-term care facilities, nursing facilities. And this would, I think, help in many ways. We're talking about a very fragile population. So any insight or reflection our panelists would have on that, I would certainly appreciate. I know that, when we look at rural healthcare, I think it's important to even note the fact that there's a difference between rural and even remote. I have 75 counties in my congressional district. And so, we have communities of 50,000 people. We have counties of a few hundred people. So the needs are very diverse, and the logistics obviously are very different. And so I hope that we can always keep in mind when it comes to underserved populations, could be in highly urban areas too. So we need the flexibility in public policy to reflect the needs of a local community. Federally qualified health centers, I think, in Nebraska happened to be, before I even got to Congress, happened to be in my home community of about 40,000 population. And I really commend them for what I see as a very efficient delivery of services. So as they expand their offerings, perhaps through telemedicine, I hope that we can keep their efficiencies in mind as well, and offer them the flexibility that they feel that they need to meet the needs of the patients that they see. I would be curious to know from our providers on the panel, when it comes to reimbursement, say for a visit, whether it's an in-person visit or through telehealth, could there or should there, right now we have some discrepancies, perhaps unintended. Well, I know they're unintended just based on the history and the numbers, but would you see a differentiation in the reimbursement levels in terms of a visit via telehealth versus in person?
Maybe I'll jump in as one of the providers on the table. So, Representative Arrington had also asked the question about about the issues related to how do we make sure we don't have the fee-for-service churn. And so, to go to your question, Representative Smith, my view is that how do we ensure that we are not we're using telemedicine appropriately? One aspect of that is, as I articulated in my opening statement, is to ensure that we don't overpay for it. I think what we need to try to do in the United States is encourage efficiency, and telemedicine can be, but that I think because providers can do that within their homes and need less overhead, that the reimbursement in the long term should be less than it is for an in-person visit. And I think that'll be one way to both check overuse as well as to encourage that efficiency in the U.S. healthcare system. So that's my views on the payment aspect for the video visits.
Okay,
The
thank you.
gentleman's time has expired. We will now the chair now recognizes Congresswoman Judy Chu of California. Congresswoman Chu.
Yes. Thank you, Madam Chair. Ms. Myrick, I'd like to thank you for sharing your testimony, not only as a person with lived experiences, but both as a user and a professional in the mental health system in this country. I was so impressed by your testimony. But also, I'm thrilled because you are a resident of Los Angeles County, and that's where my district is. Also, I am a psychologist and a graduate of the same school that you graduated from. So there are many points of connection here. Well, as a psychologist, I'm extremely interested in the way that peer support services can be used to enhance our mental health system, which is why I'm working to develop legislation with my colleague Adrian Smith from Missouri that would define peer support specialists as eligible providers as part of a coordinated care system and team in the Medicare system. So I was very intrigued by the specific challenges that you say that the residents of LA County face in accessing telehealth services, particularly mental health services during this pandemic. You mentioned in your testimony the struggles that some families face in just even being able to download a mental health app on the phone or sharing phones to cut down on the costs. So can you discuss the efforts that LA County Mental Health is doing to support residents who may have limited or no internet access? And are there steps that Congress can take to support these efforts?
Sure. Thank you very much, and thank you for your work on ensuring that peers can be a part of the service array on Medicaid and Medicare. There are peer services that are certified throughout 48 states. California is not one yet. We're working on it, but throughout 48 states. In LA County, what the peers in particular are doing is they've created a digital health literacy curriculum. So the first thing we had to do is help people, if they had access to equipment, is know how to use it. If you don't know how to download an app, if you don't have email, you're using it just for basic phone stuff, but you have all the other aspects that you can utilize. They just didn't know how to use the phone and how to download and use the apps. When we introduced, of course, or expanded telehealth for the population that we serve, that was one of the things that we found that people, and the providers too, really didn't know how to use that technology. So the first thing we had to do is help people learn how to use the technology. Providers were concerned that they would be spending their time with clients on helping them to use the technology versus doing the actual appointment. So we have created a tech peer certification, and these tech peer specialists actually work with our older adults and our clients, not to get them signed up to use the telehealth platform, but they do the telehealth etiquette. They also do a lot around privacy, security, just basic stuff about the technology. And then how do you engage and participate and be activated in your care? For those that don't have the equipment, people can come to the clinics, and we set up like cubicles, and a person can come to a clinic and sit in a cubicle and have a telehealth visit with their provider if they don't have the equipment at home. For those who are unhoused, like I said, with the batteries and the chargers and all of that, we actually provided opportunities. Our peers went out, all PPE'd up and all of that kind of fun stuff. And they actually cleaned the equipment for people. They recharged the equipment for people. And again, helping them get connected to care and resources. So that we really have stepped up the game in order to ensure that people have access as best as they're able, with all of the restrictions actually and limitations that unfortunately the Lifeline program still has, and we're waiting for those restrictions and limitations to be lifted or waived during this time.
The gentlelady's time has expired. Next, we will hear for questionings from Congressman Mike Kelly from Pennsylvania. Congressman Kelly, you're up.
Thanks, Jerry, and to all my colleagues, thanks for being on today. Listen, I like what Dr. Tibbles said. That this telehealth, this isn't a silver bullet, and I think the question that most of us have, and some of you have already answered it, but when I looked at what Ms. Myrick said and what Dr. Tibbles said, I think the biggest challenge is going to be having people comfortable with actually using it, and especially seniors. Are they comfortable with using it? Do they feel they have easy access? What kind of programs do you think we have in place right now, or we should be going after, that's going to make it easier for people to use it where they're comfortable going on that type of a service? Ms. Myrick, you can answer it. Any of you can answer it because you all have certain parts of your testimony about it. So.
I'll try to make it really quick and leave some time for Ms. Myrick. By the way, love what you're doing, Ms. Myrick, out in LA. Seniors of today aren't quite the seniors of yesterday, but there are still some challenges, and we should be doing some things that I don't mind sharing with this group. My father is 70, practicing family physician in semi-rural Texas, and I've watched him go from 0 virtual visits to about 70% of his practice in a very aging population with great success. But he has shared some of these stories. So in terms of digital literacy, I think things like Ms. Myrick was talking about, and leveraging community health workers to identify and work with high-risk patients who need help in understanding how to use technology, it really becomes pressing at the point of care. We should make strong efforts to support providers and clinics who are bearing this burden to help educate patients and caregivers. So things like the Administration for Community Living, working with CMS and other stakeholders to develop strong education and training resources to account for these age-related differences and how beneficiaries interact. And then just back to the overarching principle, I think we all agree we have to make meaningful investments in these areas to close this digital divide to get the full benefit of telemedicine going forward. Ms. Myrick, hope I left you some time.
You did, thank you. So I'll just say that the first group of people that we actually trained were our health navigators and our health, they're called service extenders. And the service extenders particularly work with people who are older adults, usually people who were staying in their homes already before even COVID. So there were home visits and such. So those were the first people that we trained to help older folks get connected to equipment and get them the equipment if they were eligible. So that was one thing. So I would say a peer workforce, a community health worker workforce, and then promotoras, because of course we have people who are non-English speaking or low literacy, and these are folks that in the community, they trust them. So if you have to help somebody out to get connected to and use the technology, you would want somebody who's kind of been through it, been through that similar situation, or a trusted person in your community. So, but they need to be reimbursed for these services, and that's going to be one of the sticking points. And I would love to see, this is just, Caris is very innovative. Everybody has a TV in their home. What can be done through like a cable person-to-person TV kind of situation for an older adult who's at home and has a TV, but being able to use that TV to engage with their providers, I think would be very interesting.
Perfect. Well, we are in the midst of a telehealth revolution, so now's the time to get up and get comfortable with it. Thanks so much for everything you're all doing. Terry, thanks. Brad, thanks. All of you are really good at putting this out, so thanks so much.
Thank you. The gentleman's time has expired. The chair now recognizes Representative Dan Kildee of Michigan.
Well, first of all, thank you, Chair Sewell, for hosting this, and for all of you that have organized this task force. It's really important. So COVID-19 has meant that a lot of places, including my home state, are dealing with two public health crises at least at the same time. Coronavirus, which is obvious, but also addiction, essentially an addiction epidemic. A lot of people facing multiple stressors during this COVID-19 pandemic, including economic loss, fear of catching the virus, or isolation. So the people I represent, a lot of them are struggling with addiction, and this has made it worse. This stress has been enough to sadly knock some of them off the road to recovery. Through the CARES Act, Congress did expand Medicare's telehealth coverage, and SAMHSA loosened some methadone restrictions, for example, which have allowed some patients to still access care while staying safe from potential exposure. So these expansions have been important, and they're critical for patients with addiction and behavioral health issues. I heard from a behavioral health provider in my district that they've seen a 20% increase in attendance to now virtual therapy sessions since the pandemic hit. The provider also said that even some of their therapists and doctors who were convinced that face-to-face behavioral health was the only effective way to provide that kind of care have now come around to the benefits of telemedicine. So my state of Michigan, like a lot of the country, we have a shortage of psychiatrists and other behavioral health providers, especially in the northern, which in Michigan would be the more rural part of the state. Because of this, in Michigan, there's a high unmet need. Estimated 38% of mental illnesses and 80% of substance use disorders go untreated. So behavioral telehealth sounds like it could end up being a real win-win because it extends the reach of the existing provider supply. And I totally get Dr. Wenstrup's point about the need to make sure that we have slots in those areas, because providers are most likely to continue to work in the areas where they were trained. But in some of the rural areas, even that doesn't quite get us there. So Ms. Myrick, I wonder if you might comment on whether you think the pandemic has changed patients' and providers' perception of behavioral telehealth and how you think that might affect rural and underserved communities. And I don't have much time.
Okay, sure. So, Quickly, okay, I don't.
Can you hear me, Madam Chair? This is Gwen Moore.
Yes, Gwen, I can hear you.
Okay, I didn't think you knew.
Oh, I do. I see you. Thank you so much. I just wanted to make sure while the gentleman's time has expired, we will let the panelists answer the question.
Okay, so I'll try to answer real quickly. So a couple of things. I think that on the behavioral health side, that there probably was a belief that, and we were all already late to the game because of the way that the HITECH Act and legislation worked for people on the behavioral health side. So I think we're a little late to the game, but now we're catching up, and that's why I say that unfortunately COVID's unintended consequence was jettisoning us into the digital age. So I think people are embracing it and using it. I think one of the differences maybe that we haven't really captured within sort of the integration and the supports that people with mental health and substance use conditions need is the peer provided and recovery groups that are now online, ensuring that people have access to the recovery groups like the 12-step groups, et cetera, that they were going to in the community are now available in a virtual setting, as well as ensuring that there are ways in which people can get connected in rural settings. In Los Angeles, we are getting ready to implement what are called therapeutic transport vans, in which people, a team of a community health worker and or peer, a nurse practitioner, and I can't remember who the other, like an EMT, I think will be the driver, will drive to meet people where they are. So those are other ways in which people can continue to do in-person safely, as well as bring the telehealth to people if you need to connect to a psychiatrist or other licensed provider.
Thank you. The gentleman's time has expired. We will now hear questioning from Representative Jason Smith of Missouri.
Thank you, Madam Chair. Thank you all for being here today and for this discussion. Thanks for having me. Whenever we're looking at the current pandemic that we've been in, I think that there's one silver lining that we can look to that has happened, and that's the massive expansion of the telehealth services that President Trump and this administration has done. I know representing rural Missouri, we have seen great benefits from having telehealth visits and services extended. One aspect of telehealth where the administration has allowed audio only has been extremely important to the folks here in the 8th Congressional District of Missouri. Nearly 1/3 of all the seniors who have had a telehealth appointment during the pandemic have done so via an audio only technology. And many senior citizens, as we know, struggle with technology, have been able to utilize telehealth for the first time ever, which is extremely important in rural areas. It's very, very important. But what we do know in rural areas is that we lack the access of rural broadband. And I think that it's important to note that we picked up just the statistics of 5 different counties in our congressional district that in fact have a diabetes rate of over 14%. This is 155% above the national average of diabetes. All 5 of these counties that have it, they have one other thing in common, and that is all of these 5 counties have less than 55% of their residents who have access to broadband. And so we clearly know that a lack of access to broadband affects the adequacy of health that is provided to our constituents, and definitely with having telehealth with audio only has been very helpful, but we've seen some of the limitations there. I think that we need to ensure that rural areas are able to continue to access the care that they need. allowing audio-only telehealth to continue beyond this pandemic, I believe will improve the health outcomes for the people that I serve in these rural areas for a long time. Dr. Tibbles, the question I have, we are hearing a lot from our providers that a significant number of beneficiaries have access issues when it comes to video telehealth, and so do clinicians, and we know that that's from broadband. But could you walk us through some of the other barriers that result in some patients having greater access to video telehealth?
Sure. So I've been in this space for a while, and you don't have to be in it very long, by the way, to call it a while. But I've been having this discussion a lot around audio only versus audio visual recently, especially since the beginning of the pandemic, much less so. But every honest physician will tell you there are use cases where the visual component is necessary, but many where it's just not. And I believe providers should meet the standard of care for the given situation. But you brought up a couple of really important points. And back to my dad's story about taking care of his elderly patients, many times it's digital literacy, and you need that point of care to help walk someone through it. And that's not just unique to the elderly, but to others who lack digital literacy. You bring up the biggest one, given that 39% of the rural population does not have adequate broadband, requiring a video component may disenfranchise a very large group and further contribute to the health disparities that all of us have expressed concern about. So it's why I feel very strongly that there should not be legislation or regulation around modality. We should be technology neutral, allowing for these. And you made some of, I don't have to make them any better. You made them very well around some of the importance of why audio only is really important going forward.
The gentleman's time has expired.
Thank you.
The chair now recognizes Gwen Moore from Wisconsin. Congresswoman Gwen Moore.
Well, thank you, Madam Chair, and I want to thank all my distinguished colleagues and our panelists for joining us today. You know, I had a meeting with the providers in my area not too long ago, and they, there have been about 1 million telehealth visits since the pandemic started. And so while that's a very impressive number with regard to the numbers of people who may not have been seen, given the discouragement from just appearing in the emergency rooms or not being able to go to doctor's offices, I really feel concerned and want you to address it above and beyond the obvious challenges of actually having the modality for broadband and a computer or a smartphone. The actual skills to be able to negotiate your way. What safeguards are we building into this to make sure that we are not increasing the health disparities with regard to who's being seen? How do we know that when we're triaging people that we're not intensifying the racial disparities that we see in healthcare? Do we have safeguards for that? That's my burning question, since I can't pin the clock. Don't seem to be able to do that today. You know that question is for you, so go for it and answer it.
I'm sorry, Congresswoman.
Yes.
Yeah, Dr. Mahatra.
Oh, great. Oh, sorry. I apologize. I didn't hear that correctly. Yeah. So in terms of the disparities angle, I want to emphasize it is a very significant concern. Representative Davis, in his opening statement, summarized a study we just published this week in the American Medical Association documenting how many Medicare residents do not have that digital technology. And let's be clear that lack of digital access was greater in communities of color and our lower income population. So I think it's a really critical issue that we need to address. On a positive note, in some recent work that we've done, we've noted that because of the addition of audio-only visits, we have seen the uptake of telemedicine, either audio or video, is relatively similar across different both racial and income groups. So I think that's a really positive message and really builds on the issues that we just discussed, which is that audio visits have been a mechanism to get care into rural communities and to get into some lower income communities. And those kinds of analyses, I think, are critical to ensure that disparities are not increasing. I think the one thing that I might add just in a second here is that I'm not sure, though, we want to, I think it's very important within the context of the pandemic and for a short-term period afterwards to cover audio-only visits. But I'm concerned that we continue paying for those in the long term, because I do, as Dr. Tibbles said, that it's in many cases inferior. And I'd rather we invest the dollars into making sure that everyone has access to video visits.
Thank you. The gentlelady's time has expired. The chair now recognizes Congressman Tom Rice of South Carolina.
Well, thank you, Madam Chair Lady. I've certainly enjoyed listening to this proceeding and learned a lot. It's so exciting to hear the benefits that telehealth can offer, because in the end, what we all want is reasonable cost access for all of our constituents. And I too have very rural counties in my district that have very poor population and somewhat restricted access to broadband. Whatever we can do to expand that, to give these people access to healthcare that they've probably never ever had, it's never been available in these areas, and to do it at a reasonable price is just an exciting thing. Obviously, the one big drawback that everybody's concerned about is how do you put these guardrails up to prevent fraud, because unfortunately there are people who would take advantage of this and not provide good care and bill the taxpayers or the insurance companies for that. Dr. Davis, you mentioned in your testimony that that some people weren't offering these services because of the upfront cost of providing telehealth. What do they need besides a computer and a camera and broadband access? What do the providers need to invest in to provide this service?
Yeah, thank you. So it really depends on where the patient is going to be located. So while we are excited about the expansion,
I have very limited time, Dr. Davis, so if you can keep it really short.
I am. So if the patient is going to be in another clinic setting, there are devices that we recommend, so that the provider can conduct as close to an in-person visit as possible. So there are stethoscopes and otoscopes and things that would allow that provider to feel comfortable about the physical exam that they.
What about if the patient's calling in from their home?
If the patient is calling in from home, it is a computer. And then there's software. They have to have HIPAA compliant software in order to see the patient in their home.
Dr. Mehrotra, what is the upfront cost to a physician?
Yeah, so I think just to build on Dr. Davis, the two elements are obviously purchasing the technology, and I think that is actually more expensive because you want technology that can have a virtual waiting room and other sophistication, so you're not using, say, FaceTime. But I think the much greater investment that's required is helping your patients understand how to use that technology. Ms. Jones is in your clinic. Ms. Jones, let me walk you through how to download this app, how to get on there. And that takes a lot of training, and a lot of physicians' offices don't have people with that kind of training to help their patients access those video technologies. So that's the kind of thing that I think is necessary in the investment.
Okay. What this gets back to, what's so exciting to me is it's almost like what existed before I was even born, with doctors coming to people's houses and making in-home visits. And I don't know, without providing technology to these patients, what more they would need besides a video camera and the ability to talk back and forth. Dr. Mehrotra, besides the video aspect, where the doctor can, I guess, see some condition or indication of a condition on a patient, what's the downside to voice-only telehealth?
The gentleman's time has expired, but we will allow the panelists to answer the question.
So obviously there's the aspect of whether clinically it's as good as a video visit, and in some cases it's not. I also want to emphasize to the representatives that I am hearing some backlash from patients for audio-only visits. And the reasoning is that previously they would call me and I'd take care of them on the phone. And now all of a sudden they get a bill in the mail for $150 because it's now a audio only telemedicine visit. And for those patients, in particular, those who are paying out of pocket for that, there's also that aspect. And I worry about that patient backlash with audio only visits. So something else for you to consider.
Thank you. The gentleman's time has expired. The chair now recognizes Congressman Byer from Virginia.
Madam
Don?
Chairman, thank you very much. Dr. Marotta, I come from a family of physicians, not I, but brothers, sisters, aunts, uncles. And one of the things that I've heard again and again is that half of the healing value is in the conversation. Just taking the history itself. What is your concern about the low value conversations? And how would you define those low value conversations? Things that don't have an impact on their health.
Yeah, so I think there are a couple that I might highlight here. The one that I've been concerned about that I'm hearing about recently is in the context of you see the doctor in person for, I don't know, an annual physical. And then a week later, they call you up for your laboratory results and describe those to you over the phone, and they bill for a full visit after that. That would be an audio or video only telemedicine visit. While that's appropriate and helpful for the patient to hear those results, previously they weren't paying for that. Our taxpayers were not paying for it, but now it becomes a visit that wasn't paid for and therefore increases utilization. So that's just one example of that. Another one could be that in our research, we found that most people right now, when they have a cold, don't go get care. But when they have easy access to a telemedicine visit, more of those patients are going to go and get care for their cold and to see if the doctor thinks everything's okay. And those don't actually improve health, but it increases utilization quite dramatically.
At the same time, you have all these people that aren't going because they don't have access at all. And obviously their health should be a lot better if they finally get some access.
I completely agree. And that's why I indicated in the beginning, it's a very strong, big challenge. Those are the types of care that we may not want to encourage, but there's so many conditions that we've just discussed in today's session that are so critical to encourage. Treatment of diabetes, treatment of mental illness. So we want to encourage those kinds of uses of telemedicine, but maybe not encourage those other forms. And that's the balancing act that the policies need to address.
And doctor, you just laid out all the different things that a physician is going to have to do in order to make telehealth work. Does it really make sense, given that they're still going to have to pay rent, utility, staff, to have a lower reimbursement rate for telehealth?
Yeah, so my view on that is that there is the short-term investments, but in the long term, if you don't need to you can do more of those visits at home. You can see more patients within your practice. You don't have to have the medical assistant check them in. Those are different lower costs. And therefore, that's why I'm encouraging for the long term, those telemedicine visits be paid at a lower rate than in-person visits, because over the long term, those costs should be lower to the provider.
So it may be one of the small things we do to actually bring healthcare costs down. Right. Madam Chair, I yield back.
Thank you. The gentleman's time has expired. The chair now recognizes Ron Estes, Congressman Estes from Kansas.
Thank you, Terry, and thank you to all of our co-chairs, and thank you to all our expert witnesses for helping with this roundtable. You know, during this pandemic that we focused on, we've just seen how necessary and critical telehealth is, especially in rural areas. You know, in my district and all across Kansas, we're dealing with primary care shortages in rural areas that you know, let alone having the specialty providers there. I think telehealth's a huge benefit, and I'm looking forward to, as we come through with this current health crisis, how do we make sure that we make some of these improvements permanent? There is a concern I have. You know, we've talked about, my colleagues and I, we put forth a proposal about how do we expand telehealth use so that the use of audio only on a contingency that if the patient has a previous relationship with the provider, I understand it's important quality control, but I worry about how we make sure that it works in areas where we have provider shortages, which is the rural areas where we have these issues. So, I've got a question, and maybe this is for Dr. Tibbles and Dr. Murata, is how do we walk that line of expanding health access to telehealth without discouraging policies that address shortages of providers in these rural areas?
Congressman, thank you for the question, and it's not an easy one. And I don't know if I said this earlier. I'm on the Texas Medical Board, and these are many times very state level discussions about what is necessary to establish a patient-physician relationship. Let's first establish one fact, which at least in my world, about 50% across the country, about 50% of people identify as not having a primary care physician. So it's my view and our view that we should be able to use telemedicine to establish that patient-physician relationship. And the use of, back to something I said earlier, the arbitrary use of things like that in policy to control utilization, I don't think are optimal program integrity strategies. I think that we can find ways to put guardrails in place for appropriate utilization. And I think that it's quite important. We've talked about the audio only issue, but on this topic of establishing relationship, and you brought up a great point, you would be disenfranchising a large number of people that don't have that prior relationship to call upon in order to get a telemedicine visit.
Thank you. And Dr. Murata, do you have comments on that?
Yeah, so in this case, I agree with Dr. Tibbles that I feel that the prior relationship or prior in-person visit requirement that are also sometimes applied are problematic, and I would discourage implementation of such policies. Beyond the issues that Dr. Tibbles described, I also want to emphasize the innovation component of it. We've done some recent work on the treatment of opioid use disorders. As many of you have articulated, there's a huge problem in this country of an opioid crisis. And we've highlighted a number of really interesting companies that are emerging in that space to trying to reach those populations. But some of the in-person requirements in the Ryan-Haight Act have really limited their ability to expand and treat so many of those patients across the country who are in need. So I also want to emphasize that such requirements could impede innovation.
All right, thank you. And my time's expired. I appreciate it. I yield back.
The chair now recognizes the Congressman from Nevada, Stephen Horsford.
Thank you so much, Chairwoman Sewell. It's good to say that. It's good to see you and my other colleagues who are here today. And I'm so delighted because, we all share something in common in representing rural communities as part of our congressional district. And my district, Nevada's 4th, encompasses more than 52,000 square miles. Most of Nevada's rural and frontier communities are in sparsely populated counties that are considerable distances from the state's urban care centers. The average distance between acute care hospitals in rural Nevada and the next level of care is 118 miles. And the average distance to the nearest incorporated town is over 46 miles. So I believe that telehealth ought to be an innovative solution for patients living in vast parts of the state, but we still have a long way to go on this issue. For instance, according to a Nevada Broadband Task Force report, 65% of the rural population in Nevada lack access to broadband. In my state, even with phone visits, poor cell service and the lack of financial resources of patients hampers telehealth experiences. So Dr. Tibbles, I agree with your assessment that Congress must make robust investments in our infrastructure. In the interim and during this pandemic, what are some of the creative solutions Teladoc has taken to deliver care in places where there currently are connectivity challenges? And how do you offer quality care if a call cuts out or a patient simply doesn't have access to broadband?
Well, this goes back to some of the discussion that we've had. By the way, thank you for the question, Congressman. Very important topic. And it's why I continue to come back to this issue of not legislating or regulating modality. And at the very least, most, and as you pointed out, not all, because some people do have issues with cell service, data plans, and those kind of things. But you hit a large majority of people by allowing this audio-only component. which may limit the number of use cases that you can apply, but they're still very broad. So your specific question about what do, we keep trying to connect. That does not mean that we don't run into issues where someone just completely loses connectivity and are unable to reconnect. We know where they are. If an issue is severe or urgent enough, we know how to notify local authorities, for example, for a welfare check and those kind of things, which could come up in something like a mental health visit. By the way, mental health visits, probably my favorite use case to talk about allowing phone only or audio only type visits to allow connectivity to very rural and disconnected places. So Congressman, if I didn't answer your question directly, I apologize, and feel free to pin me down.
You have, and I know I'm out of time. I would like to follow up with you, Ms. Myrick, on just the issues of skills training, the digital peer supporters under Go, and how we can address this from a health profession, occupation perspective. I know Mr. Davis and I have the health professional occupation grants, HPOGs, that we've worked really hard to try to expand, and I think it aligns very perfectly with telehealth. But I know I'm out of time, so I will yield my time back. Thank you.
Well, the chair will recognize that the gentleman asked the question and give the panelists an opportunity to respond, since we won't have a second round of questions.
Thank you.
Myrick, you can respond.
Okay, sure. So actually, we worked with other experts in the field of digital therapeutics to develop the peer design digital health literacy curriculum. We also talked to stakeholders to find out, well, where were they struggling with their ability to use technology. So first we started with where is the need, because we didn't want to assume that, oh, this is what you need. So we, asked people, what is it that you need in order to use your computer, your cell phone, whatever, for both health, education, and just life. And that's why our digital health literacy curriculum has some very basic stuff, like how to do an email, not just how to get the app to do the email, but how do you write an email? How to download apps, how to look at whether an app, for example, has any scientific evidence behind it, and privacy. So there are a lot of different components that we looked at to support people, not just to participate in telehealth, but to be very savvy and informed digital literacy and technology citizens. And we would love to share that with anybody who's interested.
We'll follow up and receive it. Thank you, Madam Chair. I will yield back.
Great. Our last questioner is Congressman Tom Suozzi of New York. Is Tom still on the line? You can unmute yourself, Tom.
Okay, thank you, Chairwoman Sewell. I like the sound of that. Thank you so much for, now let's see, my phone just went off here. Okay. Can you guys see me?
Yes, we can. We can see you and hear you.
Okay, well, thanks so much for doing this today. Thanks so much to all the witnesses for their time. You've been on here for a while now, and we appreciate all your insight. And I appreciate the work done by Chairwoman Sewell and Chairman Davis and the co-chairs, Weinstrup and Arrington, all good group of people you've got working together here. This is such an important topic. Telehealth is such an important topic. Serving underserved communities is so important. And it's exciting to hear about all the progress that's been made during the coronavirus to try and do something that many of us have been focused on for a long time, that we've made such leaps and bounds to move forward. I'm particularly interested in senior citizens and in long-term health care, and how we can merge these ideas together. This is a very personal topic for me. I grew up in a house where all four of my grandparents lived there. Three of them were very sick. My mom and dad passed away not long ago. My dad was 95 years old. He died at home. He died 2 weeks before my election in 2016. And then my mom passed away. She was 93 a year later. And they fortunately had home health care insurance. So I'm working very much on looking at home health care and long-term health care insurance. But I want to try and bring in this idea of telehealth and how it can apply specifically to helping seniors that want to try and stay at home, and what insights our experts have regarding telehealth specifically targeted for seniors who are beginning to become less and less capable of, even doing the technology part. Maybe it could be that there'll have to be someone to help them actually do the telehealth part. So I just want to see if any of you have thought about that, and just ask for a quick comment from each of the experts.
Congressman, I'll start if that's okay.
Yep.
I appreciate that this is personal for you. I'm going to take off my Teladoc hat and share that as part of my clinical practice, I've chosen to keep long-term care as part of what I do. I think it's one of the most vulnerable patient populations anywhere, and they deserve our best. And I think in the end, society will be judged by how it takes care of the most vulnerable, and this is that group. And I just want to point out a couple of things at Teladoc. You mentioned one. We partner with AARP, things like putting technology in place to allow three-way video conferencing with caretakers, especially educating people on how to take care of geriatric patients through technology, those kinds of things. So I know there's not much time, and I'm going to stop at 15 seconds so that someone else can pick it up. But I think this is an incredibly important topic and support expansion in that space.
The chair will allow each member of the panel to respond to the gentleman's question. So, Dr. Tibbles, if you have more to say, please.
Congresswoman, I always have more to say, but I'm going to resist the urge, and I'll yield to my colleagues. Thank you.
All right. The other two panelists are allowed to answer the question as well, since this is our last question.
I'll maybe just jump in on that topic because Dr. Tibbles mentioned long-term or nursing homes, and I wanted to emphasize where their telemedicine really that's one area that I'm very enthusiastic about use of telemedicine. There has been some good research documenting that if we can provide telemedicine, in particular for after-hours coverage, we can prevent seniors from having to go to the emergency department and be hospitalized. And that's good for them, so they can avoid having to go into the hospital unnecessarily, and obviously good for their family members and also society as a whole. So that's one application where I think it's expansions in that area would be great.
That's great. Thank you. Anybody else?
Yeah, I'd like to respond. One of the great things about our remote patient monitoring program was that it was very easy, or it is a very easy program for our senior citizens to use. One of the questions that we have often been asked was, what about our senior citizens? Are they able to use the equipment properly? And we did learn that with a quick run through, a walkthrough of how to use it, that they were very comfortable with the equipment. One of our major spokespersons for that program is in her 70s. And she actually would tell the people in her community how easy it was. One of the things that we do for our audiovisual visits that we had to implement during this COVID crisis was, again, asking people to, do you have a granddaughter? Do you have a grandson? Do you have a family member that could join your visit with you and help you with this? So that's one of the things that our providers did on the front end when they were trying to determine who was appropriate for a telehealth visit. There were no assumptions made. Even if they had a smartphone, there were no assumptions made about whether or not they knew how to use it. If they were in for a clinic visit and were planning to have a telehealth visit for the follow-up, they were trained at that time with whoever brought them to the clinic visit. So there again are multiple opportunities for us to be able to use our resources to help our senior citizens, even those that are in long-term care facilities.
And I'll just add that one of the things that we had an older adult, it was so beautiful to see, participate in a peer group meeting. And I kept asking, who's that person who's with her? And it turned out it was her in-home support service worker. And she had on her PPE, but she actually helped the person to get set up to use the technology, because the person also had visual impairments. And I don't want to forget our folks, whether they're old or young, who have various disabilities, that we have to ensure that they can participate using telehealth as well. But she was able to participate. And the one thing that she said was, I'm so lonely. Being able to do this once a week gives me connection to community. So it is our in-home supportive service workers who can also support older adults and others to use the technology.
Well, I want to thank all the witnesses so much, and thank you, Madam Chairwoman. There's a real storm coming in our country. The number of people over 65 is going to double by 2050, and there are less and less people to take care of those folks. In the early 1900s, there were 30, 40 people that could take care of every senior citizen because people didn't live as long and families were all nearby each other. Now, because of travel and transportation, now because of young people having less children, people moving to different areas, there's less and less people available to take care of our seniors, and our senior population is growing rapidly. So this is so important. Telehealth can be a big part of it, and I really appreciate the opportunity to have a chance to speak to the witnesses. So thank you so much.
Well, thank you. The gentleman's time has expired, and so has our time for this roundtable. On behalf of the Ways and Means Rural and Underserved Communities Health Task Force, co-chairs Winstrup, Arrington, Davis, and myself, I want to thank the panelists and all the members for joining us today on this very important topic of telehealth, COVID-19 and beyond. Thank you all, and this roundtable stands adjourned.
Thank you, Madam Chair.